Hello all, I am Dr. Ashish. In this video, I am going to discuss about the interpretation of the HPLC reports for hemoglobinopathies in India. Okay, this is a diagram of the HPLC principle. HPLC is a high performance liquid chromatography. High performance liquid chromatography, or it is also called as a high pressure liquid chromatography. Here, the sample and the eluent buffer is injected to the HPLC column through the HPLC pump. This column is made up of the silica material. Okay, and based on the interaction of the compounds present in the sample with the HPLC column, their molecules will be separated and they will be detected with the help of detector, and we get the data, and from that we interpret the reports. Okay, now we will see about the common hemoglobinopathies in India. As we know, hemoglobinopathy, there may be qualitative hemoglobinopathy or quantitative hemoglobinopathy. Okay. In qualitative hemoglobinopathy, there is a change in amino acids, of the either alpha chain or beta chain because of the mutation of the gene. The example of qualitative hemoglobinopathy is HbS, HbC, HbE. Okay. While in quantitative hemoglobinopathy, there is a reduction in chain synthesis. Okay. There will be reduction in chain synthesis. Maybe if alpha chain is reduced, then it is the alpha thalassemia, and if beta chain is reduced or not synthesized, it is a beta thalassemia. The common hemoglobinopathies in India, they have a either alpha chain variant or beta chain variant. Okay, so which are the alpha gene variants? So HbJ Meerut, okay, that is a alpha chain variant, plus HbQ, which has a peak around 4.5 to 4.7, and it is percentage will be around 15 to 25%. HbJ Meerut will elute at the P3 of the HPLC system, P3 region, and the percentage is around 15 to 25. Because there is a single gene mutation of the alpha chain, this HbJ and HbQ, they are clinically silent. Coming to the beta chain variants, there is a HbE which elutes with the HbA2. There is a HbD which peak at 3.8. There is a HbD window in HPLC Biorad that will be around 3.90 to 4.30 minute retention time. HbS will be detected as the HbS window. There will be retention time of 4.3 to 4.9. While HbC will elute at 4.90 to 5.30 retention time. Here, this HbE, HbD, HbS, HbC all may be either heterozygous or homozygous. In case of heterozygous, the percentage will be around 20 to 40%. But if the percentage of that hemoglobin, abdominal hemoglobin is 70 to 90%, it will be the homozygous. So suppose the HbE concentration is around 75, you can say it is a HbE homozygous. Okay, and it will elute with the HbA2. And because of the lack of the awareness of the couple regarding the screening for the hemoglobinopathy, there may be the double heterozygous child. Okay, one of the couple having HbS and other partner having beta thalassemia, then the child have a chance of the double heterozygous for the S and beta thal, double heterozygous for the S and D, double heterozygous for the E and thalassemia. Okay, so this double heterozygous is very common also. So this is a Biorad variant windows. You can see there is the F window, P2, P3, A0, A2, D, S and C window, and the retention time is different. Okay. Now, which are the strategy to be followed to diagnose the patient? So the clinical correlation, patient's clinical conditions, patient's signs, symptoms, okay, everything is important to give the final diagnosis. Because this is a genetic disorder, the diagnosis will be the lifetime. Okay, so we have to check everything before giving the final diagnosis. So we have to correlate with the signs and symptoms of the patient. We have to see the CBC reports. We have to see HB, MCV, MCSC, RDW, RBC count, everything we have to take into account. Then blood films, okay, peripheral smear is very important. Then HPLC, alternative technology can be used like hemoglobin electrophoresis in agarose or capillary electrophoresis. Okay, and final diagnosis, final confirmation with the help of DNA sequencing. The family history is also important. We require the parental screening also. Okay, screening of the family members. age of the patient is very important. Also the history of blood transfusion. Okay, so everything we have to take into account while giving the final report of the patient. Okay, so this is a diagram of the HPLC chromatogram. We have to see the concentration of HbF, HbA2 and adult hemoglobin. We have to check for the quality of the chromatograph. So we have to see the total area. This area should be between the 10 to 40 lakhs. Okay. Then QC should be passed. This area should be straight line. There should be straight line. Okay. Base should be the straight line. The peak should be the sharp. Okay. These are the things that you have to look in the chromatograph. Okay. You can see the HbA2 level is 6. Normal HbA2 level is 2 to 3.5%. Here it is more than 3.5. So it is more of suggestive of beta thalassemia minor. Beta thalassemia minor. Okay, HbA2 between 4 to 9 is suggestive of beta thalassemia minor. But here again you have to correlate with the CBC reports. Okay, hemoglobin will be low, MCV will be low, microcytic hypochromic anemia will be there. Plus, you have to also see whether patient have a vitamin B12 deficiency or not. Because vitamin B12 deficiency lead to the megaloblastic anemia and it will lead to the increase in HbA2 level. Also, hyperthyroidism. Okay. Hyperthyroidism and vitamin B12 deficiency is very important reasons for elevation of HbA2. So, you have to see the CBC reports, rule out other cause that will increase the HbA2 and then give the diagnosis of beta thalassemia minor along with the family screening and confirmation with the DNA sequencing. So based on the HbA2 concentration, we can give the diagnosis of different disease. So 2 to 3.5% is normal. Okay, 4 to 9% is beta thalassemia trait. Okay, along with the you have to correlate with the CBC findings. Okay, if the level is between 10 to 19, it is Hb Lepore, where there is a beta delta hybrid is there. If HbA2 is between 22 to 37, okay, it's, as we know, between 20 to 40% is a heterozygous. So 22 to 37 and around 35% that is a HbE trait. This HbE trait is very common in northern east part of the India, mainly in the West Bengal and Assam region. This HbE is very common. Okay, and if the level HbA2 level is between 70 to 90%, it is HbE homozygous or HbE disease. Okay, if that HbA2 level is more than 40 to 50%, between the 40 to 50%, it may be the HbD Iran. We will see the case also. Here, you have to take care of the factors that will affect the HbA2 value. As we have discussed, hyperthyroidism, megaloblastic anemia, they will increase the HbA2 level. Other causes like antiretroviral therapy, okay, and unstable hemoglobinopathies, they will increase the HbA2 level. While factors that will decrease the HbA2 level like severe iron deficiency anemia, delta beta thalassemia or HbS disease, okay, or Hb Lepore. These are the very common causes for decrease in HbA2 level. The normal level is 2 to 3.5% and patient's HbA2 level is 3. Okay, so that does not rule out the patient is normal and patient does not have beta thalassemia minor, because there can be beta thalassemia minor, beta thal minor with concomitant iron deficiency. Okay, so you have to look for the CBC reports. Okay, we have to look for the Menzer index. Okay, if it is more than 30, it is suggestive of iron deficiency anemia. If this index is less than 30, more likely of beta thalassemia minor. But you have to also see for the iron, TIBC and ferritin level, and then rule out the iron deficiency anemia. If the patient have iron deficiency anemia, we have to give the treatment for the 3 months, then repeat the HPLC and then confirm the beta thalassemia minor. Okay. So you can see here this HbA2 level here percentage. Okay, area is 5.3, HbA2 is 5.3, so it is suggestive of beta thalassemia minor. Okay, and correlate with the CBC finding. Okay, beta thalassemia minor will be 4 to 9%. Okay, so how you can report that chromatogram is suggestive of the beta thalassemia trait confirmed by the parental screening and DNA analysis and correlate with the CBC and peripheral smear finding. You have to also give notes like value, high value can be megaloblastic anemia, aplastic anemia, unstable hemoglobinopathies or hyperthyroidism. Okay, hyperthyroidism. So all will lead to the increase in HbA2. blood transfusion can interfere in the results and interpretation. Okay, and iron deficiency anemia lead to the low HbA2 level. So all these notes you have to give in the reports. So here you can see the S window is seen, okay, and percentage is 34.5. So it is between 20 to 40%. So it is a HbS trait or sickle cell trait. In electrophoresis, you can see band at the A region and S region. That is suggestive of HbS trait. Okay, this patient do not have such symptoms, but when they go to the high altitude in low oxygen, there can be precipitation of the sickle cell crisis. Here you can see the S window is seen and the area is 75%. Okay, so as we know, 70 to 90% is the homozygous. Okay, so it is a HbS homozygous. In HbS homozygous, many times the fetal hemoglobin is seen, and it is around fetal hemoglobin will be 10 to 20% in case of sickle cell disease. Patient have anemia, severe anemia, jaundice, and painful crisis. Okay, and it will be increased in exertion, or like heat, cold, rainy season, or playing sports. After that, there will be precipitation of the crisis in the case of sickle cell disease. Okay. Here another chromatograph. You can see the HbA2 level is 34. So it is between 20 to 40%. So it is HbE trait. HbE trait. As such, it is asymptomatic or mild anemia can be seen in case of HbE. Okay, you can see in electrophoresis band at the A2 region, which is similar to A. Okay, so concentration is around 34%. So that is the HbE trait. Okay, here HbA2 level is 77. So it is between 70 to 90. So it is called as the HbE homozygous. Right? Okay, and patient have a mild anemia with reticulocytosis. Anemia, microcytosis, reticulocytosis, that will be seen in case of HbE homozygous. This is a chromatogram of patient having a D window, okay, and retention time is between 3.9 to 4.30, right, and it is 32%, so it is a HbD, okay, heterozygous, that will be HbD Punjab, okay, where at beta chain 121 amino acid, that is glutamic acid, is replaced by the glutamine. Okay, in electrophoresis, it will be seen at the S region, but the solubility will be negative. Okay, if patient has a sickle cell trait, solubility test will be positive. So here there is a HbD heterozygous. Patient is as such asymptomatic. In HbE at the beta chain, okay, glutamic acid is replaced by the lysine at 26 position. Right. Now this is a special case of HbD Iran. It is mainly found in Iranian people, Pakistan, African, and Italian. In India, it is mainly seen in the Punjab area. Here, the HbA2 level is 41%. So if it is between 40 to 50%, there will be HbD Iran is more likely. While in case of HbE trait, okay, the A2 percentage will be 20 to 40%, mainly around 35%. Right. So here there is the capillary electrophoresis picture of the patient. This HbD Iran will fall in the D region in case of HbD Iran. Okay, while it will be at the HbA2 level in case of HPLC, but concentration is important. Okay, HbE trait cannot be more than 40%. Right, so that is the differentiate point. Now you can see here there is an unknown peak. Okay, at area is 19.2. Okay, and retention time is 4.7. So this is a HbQ India. This is a HbQ India. Okay, this HbQ India, there is a at 64 codon, aspartic acid is replaced by the histidine. It is mainly seen in the Sindhi family and in Goa. Here the concentration is around 15 to 20% of the hemoglobin Q. Patient have a mild anemia. Most of the patients have a mild anemia or clinically silent. Okay. Here the HbA2 level is 12.1. Okay. So we have discussed 4 to 9% is beta thalassemia trait, and 10 to 15% of HbA2 will be Hb Lepore. Hb Lepore. As such, it is very rare. In HPLC, there is a typical hump appearance of the HbA2 that is suggestive of Hb Lepore. Here, there is a hybrid gene form of the delta and beta. it is formed by the unequal crossing over during meiosis with deletion of the 5' region of the beta chain and 3' region of the delta. So this portion will be deleted and there will be the delta beta hybrid. Okay, 5' delta, 3' beta hybrid is seen in case of Hb Lepore. Here the percentage is 10 to 15%. It is elute at the HbA2 level. Okay, a patient have a mild anemia and microcytosis. It is found in the Greek, Italian, and African people. In India, it is mainly seen in the Agrawal and Mehta's family. Okay, this is here you can see this chromatogram. At the P3 region, there is a peak which is around 20 to 25%. That is suggestive of fast moving hemoglobin, that is HbJ. Okay, in electrophoresis you can see it has moved faster than the HbA. This is HbA, so HbJ is move faster than HbA. Okay, why so? Because there is a at 120 codon, alanine is replaced by the glutamic acid, which is a negatively charged. Okay, so as in HPLC also the column is negatively charged, so it will elute faster. In electrophoresis also, because it is a negative charge, so it will migrate towards the anode. Okay, so at 120 position, alanine is replaced by the glutamic acid in case of HbJ Meerut. Okay, as such, clinically it is a silent condition. Okay. Now, because of the globalization, we see the HbC window also. HbC is mainly seen in the African country, but in India, rarely it can be seen in patients who migrate from the African region. So it is a 36% in the C window, that is suggestive of HbC heterozygous. HbC heterozygous. There are many hemoglobinopathies. At every window, there can be many hemoglobinopathies. I have discussed only related to the India. Okay, like you can see here, there is a at the P3 region there can be Bangkok, Bangkok, HbJ Meerut, Baltimore. Okay, like that. Or there is a HB New York also. Initially, they gave the hemoglobin alphabetical letter to the abnormal hemoglobinopathy like HbS, HbQ. But you know there are more than 1,500 hemoglobinopathies can be there. More than 1,500 variants of hemoglobins are there. You can find details in HBVAR website. Okay, so after that, the scientists have gave up the letter like S, Q, or J, etc., and they gave the name of abnormal hemoglobin based on the location. Right? You can see there are so many hemoglobinopathy can be seen, but I have mainly discussed hemoglobinopathy related to the India. Okay. Now there are, because of the lack of screening of hemoglobinopathies in couple, the child may have a double heterozygous condition also. Here you can see the HbA2 is 50% and F is 46.6. Okay, so you have to remember HbA2 if it is more than 50, okay, and HbF is more than 10 or 20%, that is suggestive of the HbE, double heterozygous of HbE and beta thal. Double heterozygous for HbE and beta thal. The patient have a pallor, okay, or fever. Okay, many patients have a pallor and fever, but there are some atypical features can be also there. Patient may have abdominal pain, abdominal lump, paraplegia, jaundice. So many clinical manifestation can occur. Okay, so even we have seen that patient, this HbE thal patient was admitted in the surgical ward. Okay, so you have to rule out this also. Now see this chromatograph, HbS window is 63% and HbA2 is 4.2. So this is a double heterozygous for HbS plus beta thal. Okay, patient have a double heterozygous for HbS and beta thalassemia. Okay, this is a double heterozygous condition for HbS and HbD. Both HbS and HbD trait, they are individually asymptomatic, but in case of double heterozygous condition, there will be a moderately severe sickle cell anemia, which is mainly found in Punjabis Muslims. There can be double heterozygous for HbS and HbE, where there will be S window and peak at the S and E, both window. Okay. Here there will be peak at the HbS as well as HbD window. Okay. Now, here the fetal hemoglobin is 94.3. So it may be the hereditary persistence of fetal hemoglobin. If it is a trait, the percentage will be around 15 to 30%. But HPFS homozygous condition, it is 90 to 95%. Okay. Clinically, as such, there are mild anemia or no symptom, but we have to see this HPFH. So fetal hemoglobin of 94.3, it can be HPFS homozygous or even beta thal major. But we have to ask for the blood transfusion history. In case of beta thalassemia major, patient is severe anemic, severe pallor, and it requires a frequent blood transfusion. Well, in case of HPFS, they don't require the blood transfusion. Okay. Yes, you can see it is suggestive of HPFS homozygous or beta thalassemia major or double heterozygous for beta thalassemia and delta thalassemia, and double heterozygous for beta thalassemia and HPFH state. Okay. Here, the fetal motion is 93.4%, and we ask the history. Patient requires a frequent blood transfusion. So it was a case of beta thalassemia major. Beta thalassemia major. Okay. So this is all about the today's lecture. We have seen the most common hemoglobinopathies is HbS trait and HbS disease. Okay. Then beta thalassemia trait, and beta thalassemia major. Okay. There can be HbE trait as well as homozygous HbD, that is Punjab. Okay, that can be heterozygous and homozygous. There will be HbJ Meerut, HbQ India, and Hb Lepore, and there will be double heterozygous condition like HbS plus D, HbS plus E, HbS plus beta thalassemia, okay, HbE plus beta thalassemia. So this all you have to keep in mind. I hope you find this video helpful, and this will be very useful for all medical professional and technical staff working in the laboratory. And if you like this video, please hit the like button, share this video to your friends, subscribe to my channel, and press the bell icon so that you can get notification for all the videos. If you have any doubt, please write in the comment section. You can also email me on my email ID, okay, for any query. Thank you for watching. Bye.